So this session will be recorded and published on the BHA website. After this session, you will receive an email with the links to be able to review this presentation. But thank you all for joining us today. I'm super excited to be able to walk you through the feedback that we have received on the Administrative Burden CCAR and DACODS Modernization Report. My name is Megan Lenz. I use she, her pronouns, and today I will be presenting on the feedback that BHA has received from the provider community on the Administrative Burden CCAR and DACODS Modernization Report and the corresponding BHA responses to the feedback that we have received. I am an experienced designer on BHA's technology team. I have experience working in both private and public sector, and I'm now focused on improving behavioral healthcare technology and systems in the state of Colorado. I want to genuinely thank all of the members of our team who contributed to this very large body of work and all of the providers who engaged with this report and spent time providing really thoughtful feedback on this report. For today's agenda, we are going to start by reviewing the research findings and recommendations that were shared in the report and in the previous share-out sessions in October of 2023. These share-out sessions were recorded and can be found on the project microsite. My colleague Abigail will be dropping in relevant links in the chat throughout this presentation. We will then be sharing feedback that we received from providers. We received about 50 feedback responses, so we will really be using this presentation time to share the most prevalent themes of feedback and the corresponding BHA responses to those themes of feedback. Full feedback and BHA responses are published on that project microsite, and we encourage you all to review the full feedback document there. This session is a continuation of a comprehensive engagement for recommendations from the broader admin burden report to truly ensure that we are holding space for co-creation with providers and people seeking care in Colorado. So what you can expect from this presentation is that I will be presenting content for about 30 minutes, and then we will hold about 30 minutes for discussion. We might not have all of the necessary people or information to answer all questions that are asked during this session, but we will follow up with answers as needed. During the roughly 30 minutes of presentation, please feel free to put questions or commentary directly in the chat. During the discussion time at the latter half of this session, we'll be able to review those questions and come to voice for any discussion points. So to begin, we are going to be resharing the top findings and key recommendations from the broader Administrative Burden Report. We would like to start by reiterating BHA's responsibility. It is imperative that BHA addresses the administrative burden and negative impact on provider-client relationships caused by CCAR DACODS, while also remaining in compliance with federal requirements. The top findings from the report are as follows. First, the data model for CCAR and DACODS is clinically and culturally out of date, especially for elements like gender, race, and ethnicity. The second, inflexible data intake into BHA systems results in providers losing out on payment and accurate counts towards contractual requirements. The third, the distinction between CCAR and DACODS perpetuates siloing of behavioral healthcare and creates high levels of data duplication for the rising population of dual diagnosis clients. The fourth, basic usability issues with BHA systems increase the time, the effort, and the cost required to submit compliant data from the provider side. Number five is the data generated today by CCAR and DACODS really provides limited benefit to the state's behavioral health ecosystem at large. And the sixth, CCAR and DACODS requirements are directly and negatively impacting how people experience behavioral health care in Colorado, especially for intake appointments. So from our top findings, we do have 5 key recommendations that do summarize the findings. The first recommendation being that we need to update the data model through relevant stakeholdering and federal review processes. The second recommendation being that we need to select a data entry system by performing an analysis of existing technology systems, both internal and external, and using these recommended design parameters to aid in selecting a new front-facing system. We need to build for episodic reporting through aggregation of encounters and representation of a client in more of a longitudinal way to provide a whole person view through episodic reporting. We need to create data analysis dashboards to facilitate data sharing between BHA and providers, allowing for tracking towards contractual requirements and measures of equity. And fifth, we need to prioritize engagement with providers and other key stakeholders to stay true to BHA values of co-creation. So moving into the next section of this session today, we are going to be focusing on the community feedback that was received on the modernization report, as well as the BHA responses. BHA collected feedback on the administrative burden report until October 27th of 2023. We received roughly 50 feedback submissions through the feedback form, through questions from live sessions, and through email. Feedback received was published on the CCAR and DACODS Modernization project site with corresponding BHA responses, and we encourage everyone to review that document in its entirety. It is on the project microsite. During the rest of this presentation, I will be highlighting some of the common questions and common themes of feedback that BHA received, as well as BHA responses to the feedback. At a high level, there were 4 key themes that most of the received feedback fell under. The first theme was related to federal compliance and the data model. Respondents posed questions and asked why CCAR and DACODS are required, and how can the data model be updated to reduce and address the administrative burden identified through the report. The second theme focused on technology system modernization. Respondents expressed that difficulties currently exist with the current technology systems. How will the modernization effort address technical usability of these technology systems? The third key theme was related to electronic health records, or EHRs. Many organizations currently use additional technologies such as EHRs. How is this being considered in the broader modernization efforts? And that fourth key theme being engagement through training and onboarding. Respondents expressed that it can be difficult to onboard staff to these data instruments and to the state systems. How will this modernization effort address training and provider engagement? So now we'll be moving into slides for each of these themes of feedback. The first slide will pull some pertinent quotes from some of the feedback that we received, and then we will lean into the BHA response to those themes of feedback. So focusing first on the feedback that we received saying, why are CCAR and DACODS required? These feedback responses asked questions about why BHA requires CCAR and DACODS submissions, especially as the report outlined that they are largely contributing to the broader administrative burden. Feedback also included the heavy administrative burden providers currently face as a result of requiring CCAR and DACODS submissions in the form they take today through those data instruments. So why are CCAR and DACODS required? CCAR and DACODS are federally mandated data instruments required by SAMHSA. BHA is contractually required to submit this data to receive block grant funding from SAMHSA, which allows BHA to administer state-specific programs for both mental health and substance use disorder treatment. In order to maintain this block grant funding, BHA must submit data on program participation, on the utilization of these block grant funds, and client-level data to SAMHSA on an annual basis. This slide was shared in previous share-out sessions and represents why we, unfortunately, cannot simply do away with CCAR and DACODS. These two data instruments stem from reporting requirements from SAMHSA for block grants that the BHA passes on to providers. This is similar to how CMS requires reporting from HCPF on Medicaid enrolled providers. Many people have rightfully asked, why can't the BHA simply pull the necessary data from other sources? Unfortunately, we have found that there is enough difference in the type of data required by SAMHSA that there will likely, at least for the near future, always need to be some data collected from providers by the BHA. Moving into our next theme of feedback, all related to the data model and specific data elements that are collected on CCAR and DACODS in their forms today. Feedback responses spoke to the existing data model in the data elements that are required for both CCAR and DACODS. Respondents noted that it can be unclear why certain data elements are required and that certain data elements do not seem relevant for collection during intake appointments with clients and can even cause harm. Additionally, respondents share that there are no feedback mechanisms once data is submitted to BHA. We know that the data model being used today for CCAR and DACODS is outdated and harmful. There are certain questions that CCAR DACODS must ask because they are dictated by the federal government and by SAMHSA. Other questions, however, were added by OBH because they wanted to collect additional demographic information for statewide data analysis. Our recommendations include minimizing data elements to only those that BHA can solidly defend, either due to federal requirements or a strong use case for quality and access measures that would be shared back to providers and shared back to the general public. BHA plans to engage with stakeholders on this data model, and at the end of this engagement, we should only be left with data entries that we can solidly defend and have explicit purpose for. The next theme of feedback related to technology systems and the usability of these technology systems in their states today. BHA received feedback directly related to the technology systems currently in place for CCAR and DACODS, CCAR and TMS respectively. Feedback shared that these technology systems are viewed as outdated, they're viewed as difficult to use, and they significantly contribute to administrative burden and the need for additional staff to submit these data requirements and these data instruments. We know that one of the major pain points for CCAR and DACODS is the aging technology. BHA will be evaluating and selecting a new data entry technology system to complement our data lakehouse vendor, Snowflake. A successful technology system will address basic usability issues among other key identified capabilities. The evaluation and selection of this new data entry technology system will be chosen with provider input, including a stakeholdering process to ensure that we address provider questions and needs prior to selecting a new technology system. The next common theme of feedback was related to electronic health records, or EHRs. Feedback responses posed questions about electronic health records and how technology like these relate to existing provider workflows and data reporting to BHA. Feedback notes that many providers currently utilize different technology systems, including EHRs, and would benefit from some sort of EHR connectivity with data collection requirements for BHA. BHA plans to engage in a broader and more comprehensive EHR research and strategy effort to support BHA's entire technology infrastructure. BHA acknowledges that to truly design an equitable solution, the technology system must work as well for providers with EHRs as it does for providers without EHRs. BHA plans to take the cost of changes providers and intermediaries must make to align with changing reporting requirements into consideration when modernizing CCAR and DACODS. The next common theme of feedback was related to engagement and training on the data model and technology systems that exist for CCAR and DACODS. Feedback respondents shared that product adoption and system training is often difficult. Errors in data submission and resolution of these errors is time-consuming and adds to the already heavy administrative burden that many providers feel when they are submitting required reports through these existing data instruments. BHA needs to improve the onboarding, training, and user experience for providers. This includes rewriting training materials with a trauma-informed lens, selecting a new tech system with improved usability, among other efforts. These improvements to training and onboarding will be co-designed with providers to ensure that we're providing clear and targeted communications on our data reporting processes. As previously shared in the earlier sessions back in October, the success of this modernization project hinges on accurate and transparent communication, engagement, and training opportunities. We must look beyond a technical solution and into the principles of co-design to really move this body of work forward with our provider community. This includes, but is not limited to, engaging with the Behavioral Health Administration Advisory Councils, further understanding the impact and opportunities of behavioral health administrative services organizations or BASOs, engaging in cross-agency collaboration, keeping providers informed of project activities through proactive communication, such as sessions like these, office hours, and the project microsites, and engaging with the public regarding BHA's data and privacy policies, among other things. Another key theme of feedback that we received was related to the concept of episodes of care. Feedback responses asked questions about the definition of episodes of care and the need for this definition to be well thought out to ensure that the complicated concept works well for providers as well as people seeking care in Colorado. Today, when the BHA analyzes CCAR and DACODS data, it's hard to understand an individual's holistic care journey and what impact behavioral health services have had on their lives. CCAR and DACODS are moments in time captured at someone's admission and discharge to a particular service, rather than providing a more whole person picture. One way that recommendations in this report begin to address these concerns is by defining what an episode of care might look like in a new BHA reporting ecosystem. This means linking together different service level reports, including CCAR, including DACODS, including 837 encounters for an individual into a holistic data story of their past treatments so that providers can get that more whole person picture of a client. The episodes of care model was explored and validated by past modernization work. These refreshed recommendations will set a foundation for a future where we can explore additional care coordination possibilities for both behavioral health and broader state services. BHA plans to work with providers and with people seeking care in Colorado to co-create this definition so that it will work across different services and different settings. Visualized here, we believe that by moving from encounters to episodes of care, we could provide real benefit back to both providers and clients. This effort will require heavy work with people with lived experience in order to understand appropriate levels and methods for gathering consent. Another key theme of feedback that we received was related to timelines for implementation of new parameters and new mandates from BHA. Feedback responses asked questions related to the timing of an implementation of a new data model and adoption of a new technology system. Respondents were interested in these timelines, noting that mandated changes can require varying amount of work on the provider technology side, and that must be kept in mind for these changes and updates to the current landscape. We want to express to providers that we will not be requiring any changes to CCAR DACODS entry for at least 1 year after our new specifications are released, in order to be respectful of providers' timelines as they update their systems. So looking at our tentative timelines for the year of 2024, we have two distinct tracks for both the data model and for the technology system. The data model timeline involves updating the data model for CCAR and DACODS through relevant stakeholdering and federal review processes. The technology system timeline involves performing an analysis of existing internal and external technology systems based on recommended design parameters in order to select a new front-facing data entry system. BHA plans to use 2024 to perform pilot testing, to finalize the new data model, and select, build, and launch the data entry technology system, all through co-creation with providers. This timeline is subject to change, especially because we want to make sure that we are giving providers enough time to provide feedback and implement changes into their own systems. We're also practicing really agile methodology here. We want to focus on incremental change and small bets rather than focusing on larger structured projects where we have to wait for all requirements to be gathered prior to trying new things. So it's really hedging bets on small pieces and iterative project management. So what are our next steps as a part of this project and as part of the recommendations and executing on recommendations of the administrative burden project? So we are currently in the second of 3 feedback share out sessions this week. So that there is one more session tomorrow at 4 p.m. for anyone who may want to join for another session on this particular feedback. All of these sessions will be recorded and posted on the project microsite alongside the larger full feedback documents. Following these share out sessions, we will begin forming work groups for both the data model and technology system. If you are interested in participating in these work groups for data model and technology or one or the other, we invite you to fill out the form that my colleague Abigail is going to drop into the chat. We are still finalizing details of those work groups, but we are gathering interest for those who might want to participate, and we'll be following up with more information on how these work groups will be structured in the near future. So with that, that concludes the content portion of our presentation today. I'd like to open up the floor to any questions or discussion points that were added in chat, or if anyone on the line would like to come to voice and raise any questions or discussion points that they'd like to discuss now. And I'll stop sharing so I can see faces. It looks like we don't have any questions currently in the chat, but I invite any folks who might have questions or additional feedback to either drop those pieces of information in the chat or come to voice. If you'd be more comfortable communicating via email, I can also put my email in the chat for use later on. If there are no questions or discussion points that anyone would like to bring to the floor, we can go ahead and end this session a bit early. As a reminder, this session has been recorded and will be posted on the Project microsite. You will also be receiving a follow-up email with direct links to this presentation as well as the broader feedback report. And if any other questions come to mind, I welcome you to send them via email or to sign up for that work group form. Thank you, Kendra. We really appreciate your attendance today.